Welcome to the Deep Dive, your quick route to surgical exam mastery. Today we're diving into carpal bone fractures, a must-know for any aspiring plastic surgeon facing the FRCS exam. We'll be covering key facts about each carpal bone fracture, their mechanisms, diagnosis, and treatment options.
It's important to remember that scaphoid fractures are the most common, while trapezoid fractures are the least common. Every carpal bone fracture evaluation must include a thorough median and ulnar nerve assessment, as these nerves are vulnerable in wrist trauma. Additionally, CT scans are crucial for scaphoid fracture diagnosis. They help differentiate between displaced and non-displaced types, which impacts treatment decisions and helps avoid complications like delayed unions and non-unions.
Let's start with the trichotrum, the second most common carpal bone fracture. What are the main types?
There are three main types of trichum fractures. The most common is a dorsal cortical fracture, often an avulsion fracture, where ligaments pull a small piece of bone off the dorsal rim of the trichotrum. Second are body fractures, which can happen from direct impact or crush injuries to the ulnar side of the hand. Lastly, we have volar avulsion fractures, which involve the volar ulnar triquetral ligament and the lunotriquetral interosseous ligament.
What radiographic views should we order, and how do we treat these fractures?
You'll need AP lateral and a 45-degree pronated oblique view, which provides the best visualization of the trichotrum. A CT scan is often necessary, especially if you suspect an occult fracture. Treatment for simple dorsal rim fractures usually involves immobilization with a short arm cast for 4 months. Displaced body fractures, however, require open reduction and internal fixation, ORIF addressing any associated ligamentous injuries or dislocations.
Now let's discuss hamate fractures. What are the key things to remember for the exam?
The hamate has two main types of fractures: hamulus, also known as the hook of the hamate, and hamate body fractures. Hamulus fractures are often caused by direct trauma to the hand while holding an object like a bat or club. Patients typically present with pain and tenderness over the hamate, along with edema on the ulnar side of the hand.
Are there specific tests we should perform for hamulus fractures?
Yes. Two important ones. The hook of hamate pull test, HHPT, involves having the patient supinate and ulnarly deviate their wrist while you apply force to the flexor tendons of the small and ring fingers. This stresses the hook of the hamate and can elicit pain if there's a fracture. Second, a thorough ulnar nerve examination, especially the deep motor branch, is crucial as it can be injured with this type of fracture.
What about imaging for hamulus fractures, and are there any potential complications?
Standard radiographs can be helpful, but specialized views like lateral, oblique, and carpal tunnel views are often needed to see the fracture clearly. A CT scan is frequently necessary for a definitive diagnosis. One concern with hamulus fractures is delayed presentations of small finger flexor tendon injuries, sometimes months after the initial injury. This occurs when a non-union develops, leading to a pseudarthrosis, which can cause attrition ruptures of nearby flexor tendons.
So early diagnosis and treatment are crucial to avoid that complication. What about hemi body fractures?
Unlike isolated hamulus fractures, hemi body fractures usually indicate a more complex wrist injury, often axial fracture dislocation patterns. A common scenario is a closed fist injury, where a strong axial force transmits through the fourth and fifth metacarpals, causing the hamate to fracture and dislocate dorsally.
How do we manage these different types of hamate fractures?
Non-displaced hamulus fractures can be immobilized with a cast, but the non-union rate is high, approaching 50%. Early surgical treatment often leads to better outcomes. Surgical options include ORF or excision of the fractured fragment. For non-displaced hamate body fractures, cast immobilization is also an option. However, most hamate body fractures require OR due to associated wrist injuries.
Moving on to the trapezium, another carpal bone that can be fractured. What are the key types?
Trapezium fractures are divided into two types: ridge fractures and body fractures. Ridge fractures are caused by avulsion of the transverse carpal ligament during hyperextension and abduction of the thumb.
Since that ligament is related to the carpal tunnel, should we be concerned about carpal tunnel syndrome with trapezium fractures?
Yes, carpal tunnel syndrome can occur in association with trapezium fractures and must be excluded during your examination. Treatment for ridge fractures usually involves immobilization. If a non-union develops, excision of the bony fragment is the next step.
What about trapezium body fractures?
Body fractures happen when the wrist is forced into extension and radial deviation, crushing the trapezium against the radial styloid. They are often associated with first metacarpal base fractures. Displaced fractures require ORF.
What complications should we be aware of with trapezium fractures?
Besides carpal tunnel syndrome, tendinitis, and even flexor carpi radialis rupture are potential complications.
Let's move on to capitate fractures.
Yeah.
How common are these, and what are the typical mechanisms of injury?
They're not as common as scaphoid or triquetrum fractures. About half occur in isolation, and the other half occur with other carpal injuries, often as part of greater arc injuries. One mechanism is the anvil mechanism, where hyperextension of the wrist crushes the capitate between the third metacarpal and the radius. This can lead to a transverse body fracture with a 180-degree rotation of the proximal fragment. Another mechanism involves dorsal articular fracture associated with third metacarpal base fractures or third carpal metacarpal dislocations.
How are capitate fractures treated, and are there any long-term complications?
Non-displaced capitate fractures can be treated with cast immobilization after ruling out any ligamentous instability. For displaced fractures, options include closed reduction with percutaneous pin fixation or open reduction ligament repair and internal fixation. A vascular necrosis of the proximal fragment is a recognized long-term sequela, so close follow-up is essential.
Now let's discuss lunate fractures. What are the key points for the FRCS exam?
Lunate fractures are relatively rare and usually occur with ligamentous injuries of the wrist. There are three main types: volar pole fractures, dorsal pore fractures, and body fractures. Volar pore fractures result from avulsion of the radiolunate ligaments. Treatment involves anatomic reduction, focusing on restoring normal ligamentous anatomy to support the midcarpal joint. Dorsal pole fractures often involve avulsion of the scapholunate or lunar triquetral ligaments. Importantly, these ligaments usually avulse off neighboring bones rather than the lunate itself. The mechanism is usually an axial load on a hyperextended and ulnarly deviated wrist. Treatment focuses on repairing associated ligamentous injuries.
How do lunate body fractures occur, and what imaging is helpful?
Lunate body fractures result from axial compression between the capitate and the lunate fossa on the radius. A CT scan is essential to assess the degree of displacement. Displaced fractures require open reduction and fixation.
Given the risk of a vascular necrosis with lunate fractures, prompt management is crucial, right?
Yes, prompt management is essential because of the risk of developing Kienbuck's disease, which is a vascular necrosis of the lunate. We also see...
Is there anything specific about managing trapezoid fractures that we should remember for the exam?
Yes, remember that excision of the trapezoid is contraindicated. This is because excision can lead to proximal migration of the index metacarpal, which can significantly impair hand function. Chronic injuries may require a second CMC joint arthrodesis.
Finally, let's cover pisiform fractures.
Yeah.
What are the key features of these fractures?
The pisiform, a sesamoid bone within the flexor carpi ulnaris tendon, is usually fractured from direct trauma, such as a fall onto a flexed wrist or a blow to the hypothenar eminence. Plain radiographs are often insufficient for diagnosis, and you might need special views like a carpal tunnel view or a CT scan. Remember, the ulnar nerve runs very close to the pisiform, so meticulous nerve examination is crucial.
How do we typically treat pisiform fractures?
Most acute pisiform fractures can be managed conservatively with splint immobilization. For patients with chronic discomfort or non-union, pisiform excision is often the best option.
Now let's shift our focus to the scaphoid, arguably the most important carpal bone fracture for the FRCS exam. What are the key anatomical features we need to remember?
The scaphoid is shaped like a boat and has a unique blood supply. The distal pole has a robust blood supply, while the proximal pole, which articulates with the radius, relies on retrograde blood flow. This makes proximal pole fractures more susceptible to a vascular necrosis, a key point for the exam.
What is the typical mechanism of injury for scaphoid fractures?
Most scaphoid fractures occur from a fall onto an outstretched hand with the wrist in dorsiflexion and radial deviation.
What are the essential imaging studies for a suspected scaphoid fracture?
The first step is to obtain good quality radiographs, apolateral and oblique views. However, even with perfect radiographs, up to 15% of scaphoid fractures can be missed initially. If clinical suspicion remains high despite negative initial radiographs, options include immobilizing the wrist in a thumb spica splint and repeating the radiographs in 7 to 10 days. If those are inconclusive or a definitive answer is needed sooner, a CT scan is the gold standard for diagnosing scaphoid fractures, especially occult fractures not visible on plain radiographs.
How are scaphoid fractures classified, and why is this classification important?
The most commonly used classification system is the Herbert classification, which divides scaphoid fractures into 4 types based on location and stability. Type A fractures are stable fractures of the tubercle. Type B fractures are also stable and involve the distal third of the scaphoid, the waist region. Type C fractures involve the proximal third of the scaphoid and are considered unstable. Type D fractures are fracture dislocations of the carpus, the most severe type.
How does the Herbert classification guide our treatment decisions for scaphoid fractures?
Stable scaphoid fractures, types A and B, can usually be treated non-operatively with cast immobilization. However, it is crucial to immobilize the wrist in a thumb spica cast, not just a below elbow cast. This prevents motion at the carpometacarpal joint of the thumb, reducing stress across the scaphoid fracture site and promoting healing. Stable fractures typically take 6 to 12 weeks to heal. Unstable fractures, type C and D, often require surgical intervention.
What surgical options are available for unstable scaphoid fractures?
The most common procedure is open reduction and internal fixation, ORIF using screws or K-wires. The goal is to achieve anatomic reduction and stable fixation to allow for early mobilization and minimize the risk of non-union.
What are the potential complications of scaphoid fractures?
One of the most feared complications is non-union, which occurs when the fracture fails to heal properly. Risk factors include proximal pull fractures, displaced fractures, delayed diagnosis, and smoking. Managing a scaphoid non-union often involves a bone grafting procedure, typically using a vascularized bone graft from the distal radius. Another serious complication, particularly with proximal pull fractures, is avascular necrosis (ABN). It happens when the blood supply to the proximal fragment is disrupted, leading to bone death. AVN can be diagnosed on MRI, and treatment often involves a vascularized bone graft or a salvage procedure like a four-corner fusion.
Let's move on to a couple of less common carpal bone fractures. What should we know about trapezoid fractures?
Trapezoid fractures are the least frequent carpal bone fracture. They are well protected by surrounding structures, including the trapezium second, metacarpal base, scaphoid capitate, and strong ligaments. Treatment depends on displacement. Displaced fractures require anatomic reduction and fixation, while non-displaced fractures can be treated with immobilization.
Is there anything specific about managing trapezoid fractures that we should remember for the exam?
Yes, remember that excision of the trapezoid is contraindicated. This is because excision can lead to proximal migration of the index metacarpal, which can significantly impair hand function. Chronic injuries may require a second CMC joint arthrodesis.
Finally, let's cover pisiform fractures. What are the key features of these fractures?
The pisiform, a sesamoid bone within the flexor carpi ulnaris tendon, is usually fractured from direct trauma, such as a fall onto a flexed wrist or a blow to the hypothenar eminence. Plain radiographs are often insufficient for diagnosis, and you might need special views, like a carpal tunnel view or a CT scan. Remember, the ulnar nerve runs very close to the pisiform, so a meticulous nerve examination is crucial.
How are pisiform fractures treated?
Most acute pisiform fractures can be treated conservatively with splint immobilization. For patients with chronic discomfort or non-union, pisiform excision is often the best option.
Let's wrap up our review of carpal bone fractures by highlighting some key takeaways for the FRCS exam. What are the most critical points to remember?
When facing carpal bone questions on the exam, keep in mind the following principles. First, a thorough history and physical exam are crucial, including a detailed assessment of median and ulnar nerve function. Second, understand the mechanisms of injury for each carpal bone. Third, be able to interpret radiographs and recognize when additional imaging, such as a CT scan, is necessary. Fourth, familiarize yourself with the classification systems, especially for scaphoid fractures. Fifth, understand the principles of both non-operative and operative management for each type of fracture. Finally, be aware of potential complications and their management.
Excellent points. This has been an incredibly helpful review of carpal bone fractures. Hopefully our listeners now feel well equipped to tackle this topic on the FRCS exam.
I agree. Best of luck with your studies, everyone.
That's all the time we have for today's deep dive on carpal bone fractures. We hope you found this episode helpful and informative. Make sure to tune in next time for another deep dive into the world of surgery.